Greetings, everyone. My name's Arm Laceration, and I'm faculty here at University of Maryland, and welcome to our Crashing Patient Conference. For those of you that are interested in getting CME credit for the lectures that you're going to see, you can get CME credit on EMedHome. Check it out at www.EMedHome.com. And for those people that want live lectures, we're going to be right back here in October of 2013. Hope to see you then.
Good morning. I'm here to talk to you today about the simple wound. My name is Mike Abraham, one of the faculty at the University of Maryland. I have a couple small objectives for this talk. We'll get you the things you need to know in a high impact factor. I want you to understand the medico-legal risks of wound care. Understand the different imaging modalities that you can use for foreign bodies. I want you to understand why hand wounds are so high risk. And basically, I want to keep the money in your pocket and not your lawyer's. So I'm going to start with a couple cases. First case, busy night in a single covered ED. I don't know if there's any other kind. 35-year-old male presents a few hours after an exceptionally tense Ravens game. Slipped and fell while he was celebrating a touchdown, and that's what he presents with. Second case, still single covered. It's still busy. It's a 21-year-old male who was out celebrating his birthday, and he quote-unquote slipped and fell onto his right hand. He obviously had been drinking as well. Seems benign enough. So why do we care? Well, just want to sew and go, get moving, crowded ED. Wound care litigation is pretty important. It's number 2 in claims made, and it's number 2 in dollars paid. You may not think of it up there with this missed STEMI or the missed stroke, but all those little lawsuits get added up, and it comes out to be the number 2 in dollars paid. And if you get sued, and it's still a miserable process, whether it's for a missed STEMI or because you missed something in a wound care case. So it's pretty simple to prevent litigation. Proper history and physical, proper preparation, proper closure, and then proper discharge instructions. All these together will just pretty much limit your liability. So proper H&P. We learned this all in medical school, it got beat into us in residency, but just a reminder. Important aspects of the history. When did it occur? 24, 48, 3 days ago. Just depends on when it happened. And even the possibility, is there any possibility there could be a foreign body? It's important to document and ask. The important aspects of the physical exam, I want you to document these on every one of your sheets, every time you see a patient, and that'll limit your liability as well. That you examine it to the base in a bloodless field, and you examine through the full range of motion. Both of those will also limit your liability. So preparation. There's been a paradigm shift in the last 5 to 10 years about how to clean wounds. I used to stick it in a bucket of hydrogen peroxide and let it clean. It's not that way anymore. You don't soak wounds because this promotes tissue degeneration. And you don't use cytotoxic solutions. 10% iodine providone solutions, peroxide solutions, both of these can cause tissue degeneration and make a perfect medium for bacteria to flourish. You want to irrigate properly. If a patient is immunocompetent, has a clean wound, it can be irrigated with tap water. For most of our patients who are not immunocompetent and don't have a clean wound, you have to use 100 cc's per inch of wound with a high pressure system. So to do this, I basically take sterile saline, sterile water, get a 20 cc syringe and an 18 gauge angiocath and irrigate about 100 cc's. It takes a little bit of time, but it's a lot less time than getting sued. Now, patients are always worried. It hurts, they're scared, they're in the emergency department, it's late at night, it's early in the morning, they're bleeding. And if you can anesthetize them very well, then you really have won half the battle. Remember, lidocaine plus 1% epi is now pretty much suitable for every part of the body. It was a kind of an old myth that lido with epi caused tissue necrosis. So you can feel free to use it almost anywhere now. And then what I tend to do is use regional blocks. So if they've hurt their finger, I use a digital block. If they've hurt their hand, I'll do a palmar block or kind of a ring block of their hand. Same with the ankle. I'll kind of anesthetize as far away as possible. It'll give me a suitable local anesthesia so I can actually make the wound look good. It helps with patient apprehension because they just got their finger caught in the car door, and the last thing they want is you sticking a needle in that area. But at the same time, you can also prevent wound margins from being distorted, and when you stick 3 or 4 cc's into a lip, it looks pretty bad, but if you can do a regional block, it helps. So there's less disruptions in the wound margins, and you have a nice clean closure. So in the preparation of closing the wound, missed foreign bodies are one of the most highest leading causes of litigation in wound care itself and across the spectrum. So if you miss a foreign body and you didn't look for it, there's a chance you're going to get sued, and they'll probably win. If the wound was even remotely involved with glass, I mean, maybe it was in the same room, you must obtain images. Right? There's no real defense against the fact that you missed a piece of glass because you didn't image a wound. So if it was a broken glass, if it was a person fell into a table with glass, even if they said it didn't break, there's a chance you have to make sure that you do obtain images. Glass is pretty easy to see. Other foreign bodies are a little bit more difficult, and we'll go into some of those now. That's a pretty good example of a glass foreign body, but that's not necessarily what we're going to be seeing here. This is the kind of stuff that you're going to notice. Okay, small speck there, you don't think anything of it, but if you don't get the images, you'll never see it because the chance of you seeing it, even in a bloodless field, if you examine it to the bottom, there's still a 20% chance you'll miss a foreign body with direct visualization. So try to limit that 20% down to almost 2 or 3%. You've done a good thing. So just a reminder, some of the radio-opaque foreign bodies, glass is a great one, right? It pretty much picked up with every imaging modality. Some of the radiolucent things, pieces of plastic, wood, vegetable matter, so if a person was hurt using lawn equipment or something along those lines, may not actually see it with normal x-rays. And a simple rule to remember is the higher the water content of foreign body, the less likely it'll be picked up by x-ray imaging. So, and any imaging in that matter. So if you think about it, a piece of wood or a splinter that's in the body will absorb water, and it'll take on the appearance of tissue over time, so it'll be less likely to be visualized. So you have to be careful, and that's another thing to remember in your history and physical about when the wound happened. If it happened a week ago and the person thinks there's something there and you get an x-ray and don't see anything, or even an MRI, it may just have the same water density as tissue, and it may not be visible at that point. So something to remember. What can we do to image? X-rays are great, and they're simple and easy, but they don't pick up everything, and they have some disadvantages. So if you go into the second level modalities, CT scanning, it allows for 3D localization, and that's great. Unfortunately, it has high doses of radiation, so you don't want to radiate everybody excessively. And it uses X-ray technology, right? It's just a bunch of X-rays kind of reformatted. So it may miss things like vegetable matter, and you don't really want to miss those things. Another imaging modality that's kind of gained traction lately is ultrasound. Good real-time visualization. It's nice. You can put the ultrasound on there. You can actually see where the tip of your needle is in relation to the foreign body. It's great. It can be difficult for small parts, things like fingers and toes and bottom of the feet, where there's not a lot of soft tissue between you and the image, the foreign body. So it can be hard. And sometimes it's even hard over broken skin. Remember, you need a nice fluid level to get there. MRI, great, right? But not everybody has access to MRI. It's time intensive. You don't want to send everybody for a splinter to the MRI suite to make sure they don't have a splinter. It's expensive. So I really don't use those in the acute care setting in the ED, but just as an option if you're really stuck. So proper closure. There's a few simple things you can do just to make sure you close the wound properly and to prevent poor outcomes. You want to limit your deep sutures. They're just iatrogenic foreign bodies. If you don't need a deep suture, don't put in a deep suture. All it does is cause a local reaction. You have increased white blood cells to the area. You can have sutured granulomas, and that's what they're supposed to do because that's how they get absorbed. So if you don't need to put them in there, don't put them in there. You want to make sure that the dermal layer is everted. Remember, as the wound comes up, you want the tissue edges to be slightly upward going, and you want to have no hair, no fat, nothing in that area so that it can kind of touch and start growing nicely. And then you want to make sure you preserve the vascular supply to the injured areas. If you make it so tight that it's necrotic, bacteria will flourish, it'll die, you'll have a big, nasty scar. So you don't want to make it too tight. Remember, there's only 2 real reasons why we close wounds in the ED. One is to prevent bleeding, and one is to prevent or to help with cosmetic outcomes. There's really no reason. Infection, you can leave a wound open, and it'll actually probably heal better than if we close them most of the time. So cosmetics and bleeding. So don't make it so tight that you're going to cause a problem, because it'll have a cosmetic outcome. Proper discharge instructions. You will limit your liability just by giving somebody the proper discharge instructions. So what I do, and it's very simple, while I'm sewing up the patient's wound, I give them their discharge instructions, right? So I'm telling them what I'm doing, I'm explaining to them, I'm explaining them how the wound's going to heal. Say, every wound heals with a scar. That's what happens. There's a scar that forms, your body replaces that scar over 6 months to a year, but you could have a scarring for permanently, and there's nothing we can do about it. That's just the way that it was injured. And when the patient realizes that there's nothing that it can be done, whether a plastic surgeon fixes it or you fix it or whoever fixes it, they're a little bit more understanding because it's their injury. You can always refer them to plastic surgery afterwards, but most of the time, if you do the proper closure, proper cleaning, and do the due diligence it takes when you do the primary closure, they could have a little scar, but it'll be minimized. And if you explain this to them, they really have no recourse. I always tell them that a scar is possible or even probable. No matter how nice the line is, no matter how well the wound edges match up, there's probably going to be a scar, at least for a year. If there's a possibility of a foreign body, I explain that to them. Say, look, there's a possibility there's a foreign body in there. We looked to the bottom of it, didn't see anything. We imaged it, didn't see anything, but sometimes we can't see everything. And there's a chance it could work its way out in a month, in a year, in 2 years, or in 5 years. We don't know. If something comes up, you can come back and see us in the emergency department. You can see your primary care doctor, or you can go see a surgeon to have it removed. But it should be clean. It shouldn't cause an infection, and it may just be something that presents over time. But we did our best to look for it. Wound care instructions are important, how to care for it, when to clean it, when to wash it, when to dry it, what to put on top of it, when it can go in the sun. Those things are all important. And then my follow-up information, probably the most important thing of all of them. I tell every wound that I close they need to come back in 48 hours for a wound check. And I tell my high-risk wounds that they need to come back in 24 hours for a wound check. And this basically puts the onus on them. And you say, look, come back in 48 hours. I want to look at the wound. I want to make sure it's healing right because I want to make sure that we're not getting any adverse outcomes from the beginning and catch them early. Now, if the patient chooses not to come or go somewhere else, that's the onus is on them. But you offered that opportunity and you told them what you wanted to see. The same thing happens for a high-risk wound. 24 hours, come back, see me. I want to take a look at it, make sure it's healing okay. And sometimes even if you do delayed closure, you can do things like that as well. So the follow-up information is crucial. So let's get back to this guy. What about him? Just a slip and fall, maybe some Dermabond, some steri strips or something, get out the door, ready to go. Want to move along. It's kind of busy. But you look at it and you're like, kind of interesting. Hand wounds are high risk, right? Most people use their hands for work or for fun, sometimes both. But due to the anatomy of your hand, risk of infection is high, right? There's a close location of the tendons to the skin, right? There's very little soft tissue covering to protect. It's far from your central blood supply, so the blood supply can be decreased and limited. You have a large range of motion. All these things add up to make hand wounds very prone to infection. So we're going to talk about fight bite. So you must assume that any injury over the MCP joint was caused by a tooth. Punch somebody in the face, you have a tooth injury over your MCP joints. Now, if it's a 90-year-old lady, you can pretty much assume she's not punching anybody, but you have to ask and you have to document that you asked and you have to triple document that you asked them that they didn't get this from a face. If they lie to you, that's, up to you, but, it's something you have to ask. You have to examine the tendons in the full range of motion. So if you think about it, when you punch somebody, you have a closed fist injury. As you punch them, you hit their face or tooth, you seed that part of the tendon, and as you open your hand, the tendon gets pulled back and it seeds infection all the way along that tendon sheath. So you peek in and you say, looks good, when their hand's like that. Meanwhile, when you close their hand and pull it down, you see that there's a tendon laceration or a tendon rupture in their proximal tendon that doesn't show up until they flex their fingers. So you need to make sure that you see that tendon in a full range of motion. Because if you don't, you're going to miss things. And so if you open the wound, take a look at it, don't see anything, you range it through the full range of motion, and you see a small tendon laceration, you have to assume that that came from a tooth, and as it gets pulled back in, it's seeded that whole sheath. And at that point, there's no way with local irrigation that you're going to clean that, and they need emergent referral to a hand surgeon. So you want to make sure that you don't miss those kind of things. So if you irrigate properly locally, you may still miss an infection. All right, so that's something to remember. If you can irrigate the bejesus out of it, it's not going to help. So what do? Well, sometimes you can open the wound larger. You can extend the wound margins to take a better look. Sometimes if it's just a puncture wound and you can't see very well, you do need to extend the wound margins, and you have to explain to the patient why you're doing that. And also emergent referral to a hand surgeon helps. So with fight bite, I have a low threshold for antibiotics. Human mouths are completely dirty. And so normally what I'll do is I'll give somebody ampicillin, sulbactam, something like Udicin, while I'm getting the wound prepped. So I'll give them a dose of IV antibiotics, and then I can easily switch them over to PO antibiotics for outpatient therapy. Or I can use something along the lines like clindamycin, either one, depending on allergies. They will get a dose of IV. They have good oral and IV bioavailability, and then you can watch it closely. I resist the urge to perform primary closure on a lot of hand wounds. So if I don't trust the patient, if I don't think they're giving me a good story and I'm worried about infection, what I'll do is I will splint the patient in a position of function. So I'll give them the kind of the position of function and put a splint on. I'll irrigate, I'll clean, I'll do everything else, and I'll tell them to come back and see me in 24 hours. If in 24 hours it looks okay and looks pretty well healing and the patient's immunocompetent and doesn't have any comorbidities, I can close it at that time. If there's any signs of infection in 24 hours, it makes you really worried, and you admit the patient, hand surgery, consultation, IV antibiotics, and the whole works. But if you think about it, when you do if you leave it, delayed primary closure is a perfectly acceptable course of treatment for hand wounds. So I tend to do that more and more for my hand wounds, especially if I don't trust the patient, if I'm worried that it could be a fight bite, even if they don't tell me so. Emergent hand consultation, depending on your facility, whether it's with the, within 24 hours, say it happens at night and you talk to the hand surgeon, say I'm going to send them to your office in the morning, versus if you're at a tertiary care center and you have hand or plastic surgery available to come in and evaluate the patient. Either one of those is perfectly fine. So let's go into the cases and talk a little bit about what happened. This patient, it was a great, the Ravens won, everybody was happy. The doctor was quick and in a hurry, washed it out quickly, asked the guy about the table, said I fell on the table, slid it open, sewed it back up. The guy returned a year later, and he had a foreign body, and it required surgical debridement, and he had some loss of function of his extensor tendons on his dominant forearm. So he successfully sued the EP because in documentation review, they didn't see anything that said that he had asked about a foreign body, that he examined to the base of a bloodless field, that he imaged the wound, and there was really no defense for the missed foreign body because of a poor documentation. And that case was pretty much settled. Case number 2, this patient came in, got closed primarily because he just fell, and despite the patient being intoxicated, he didn't give an honest story. It turned out that he had punched someone and refused to tell the physician. He returned 2 days later with massive hand infection and required operative debridement. And he did successfully sue the EP for lost wages because the EP did not document that he had asked him about fight bite or possibility of fight bite and didn't wait till he was sober to finish it. I mean, both of these are very unfortunate cases, but you can see these happening in a very busy ED when you're single covered and no mid-level or resident helping you out, and all of a sudden you're underwater trying to get through these patients. And so a couple simple documentation aspects and a couple simple things you could have done to help yourself out. This guy, if you had just washed him out, closed him put him in a splint and had him follow up in 24 hours to be evaluated, you would have caught the infection and probably wouldn't have had any problems at that point. So both are unfortunate cases for EPs, but this is the world we live in. So and that's what the point of this lecture is. I want to prevent these type of cases from happening. So in summary, just to wrap it all up, proper discharge instructions will save you. Good wound care follow-up, why it's going to heal as a scar, what you did, why you did it, things to promote healing, all those will help. Always, always, always obtain images that could have the possibility, or even remotely, that there's glass involved in it. And think about imaging other imaging modalities as well for other types of foreign bodies. And then resist the urge just to sew somebody up from a primary closure when there's wounds over the MCP joints. And just because it's over the 5th MCP, don't assume that it's not from a fight bite. Just because we see boxers fractures, people do not know how to punch. They punch with the wrong hand and different hands. And so just because of where it is on the MCPs, don't forget that delayed primary closure is always an option, or even secondary closure. So that's all, and thank you for your attention.